My name is Brent Mausbach. I am a clinical psychologist. I work in the Department of Psychiatry at the University of California, San Diego. And today I have prepared a presentation to discuss a research therapy that I tested recently called the Pleasant Events Program, and we called it PEP for short. It's a brief form of psychotherapy that helps to improve quality of life in caregivers. And so I'd like to start just by giving some really important acknowledgments. I'd like to acknowledge the sponsor, the National Institute on Aging. You can see here that the overall R01 research grant was entitled Reducing CVD Risk in Caregivers, a Brief Behavioral Activation Treatment. I'd also like to acknowledge Carl Ejwe and Derek Hopko, two of the pioneers of this form of therapy. I reached out to them and they were gracious enough to provide me with their treatment manual, which I adapted for caregivers. And then I'd also like to acknowledge the colleagues that I worked with on this project. Obviously, we have a team. It's not just me. And so these are the names of the very important individuals who worked with me on this research project as we progressed and found what we found in the study. I just want to start giving a little bit of a background on how and why I really developed my interest in the stresses and of caregiving for someone with Alzheimer's disease and related dementias. And this is an interesting story because it doesn't relate to Alzheimer's disease or dementias. It relates to Sophie and Betty. And I will acknowledge up front, Sophie is here on the left. That is my grandmother. And then Betty is over here on the right. That's my mother. And that is not me. That's my older brother. But I want to talk about Sophie here. She was born in 1926. Her parents passed away when she was 10 years old, within a few months of each other. So she spent her time sort of going from family member to family member in her upbringing. She got married when she was 18 years old. And when she was 50, I think it was 52 years old, her husband passed away from a cardiovascular event. And shortly after, she was diagnosed with breast cancer. And she got very depressed, not just from the loss of her husband, but from the diagnosis. And she didn't want to do any of the treatments. She kind of lost hope. She lost her drive in life. And essentially, she gave up. My mother described having her living with us. She would take pills and throw them in my mother's face and say, "What's the point? What's the use?" So you can see this hopelessness, this helplessness, this depressive mindset that took hold of her. And she passed away when she was 54. My mother, when she was 40 years old, Betty here, she was diagnosed with breast cancer at the age of 40. I was young as a teenager at the time. And I was able to see how my mother coped with it. As teenagers, we tend to be a little bit, I don't know what the word is, non-observant sometimes of the world around us, but teenagers do observe. They watch their parents and they see what happens. And I got to see my mother still engaged in activities. She'd still attend my sporting events. She would get together with friends and socialize. She would do the hobbies and interests that she kept an interest in doing those kinds of things. And she really just kept engaging in life as fully and as much as she possibly could. Now she's more than 30 years a survivor of breast cancer, and I'm actually having her out this holiday season to spend the holidays with her. And so what's the importance of this story? The importance that I got out of this, it's one of the main reasons I even went into the field of psychology, was that is it possible that the way that you cope with some of the biggest stresses in your life and have some impact on your not only mental well-being, but your physical well-being as well? And so here I am working here at the University of California, really studying this. And so that is going to be a little bit of a focus, a big focus of what we're going to be talking about in this presentation. So let me go through the outline of the presentation. The first part of the presentation will be an introduction to dementia caregiving. We're going to give you some background on the numbers of caregivers, who's providing care, some of the issues that they commonly face, and some of the consequences that the literature is showing come about from the stresses of caregiving. And then I'm going to move on to talk about this Pleasant Events program, some of the design issues that we went through. What are the two, these are randomized clinical trials, so we have two treatment conditions. What were some of the results, and what are the implications for future research and practice? So we'll start with the numbers of caregivers and who provides care. We'll give a brief overview of those topics. This is an older slide. It's from the 2000 teens. And it's really just showing the progression of aging in our society and the numbers of individuals who are anticipated to be diagnosed with Alzheimer's disease. This is from the National Alzheimer's Association. And what you can see is that right around now in the 2020s, we're looking at around 6 million people diagnosed with Alzheimer's disease. But as the decades go by, if there's no cure, we're looking at nearly a doubling of the number of individuals who will be diagnosed with Alzheimer's disease or other dementias, really. And when you have that many people being diagnosed, you're going to have individuals in their family who are going to be tasked with caring for these individuals. So the burden of taking care of individuals with Alzheimer's disease will fall on the other family members, spouses and children in particular. This is just some selected data on caregivers that I thought were relevant. In 2021, there are over 15 million Americans who provide unpaid care for somebody with Alzheimer's or related dementia. Most of the individuals who are providing care are women. It's about 2/3. Their average age is just over 50 years. The next section here talks about what are some of the what is the strain and the stress of caring for someone? We asked individuals in our UCSD study, and there was another study that I participated in some time ago. It was the National REACH study, Resources for Enhancing Alzheimer's Caregiver Health. That was a study that was done nationally in the United States across 5 or 6 cities. There were over 1,000 individuals enrolled in that study. So it's a pretty good cross-sectional view of who's providing care. And in that REACH study, the average number of hours that caregivers said that they were on duty. I have to be there. I have to be available for them. I'm not necessarily doing something, but if I'm not there, something could happen. So I have to be on duty, ready to handle anything that comes up. It's over 19 hours per day. In our study at UCSD, we found that it was approximately 17 hours a day, but it was considerable. It's quite a number. People feel like they're kind of restricted from being able to do anything but be there for their loved ones. But then we also broke it down by asking them, how many hours are you actually doing something for them? Handling bills or taking them to appointments, helping them get dressed, cooking for them, cleaning up, those kinds of things. In the National REACH study, it was over 8 hours per day on average. And you can see that it differed depending on the race and ethnicity of the individuals in that study. Here at UCSD, it was just under 8 hours per day. So again, it's considerable. People are doing a lot of things for their loved ones who have Alzheimer's or related dementias. So what are some of the common issues that caregivers face as they're doing these kinds of things for their loved ones? So they're managing activities of daily living, helping the individual get in and out of bed, helping them to get dressed, toileting, bathing, and feeding. They're managing safety issues, trying to keep the individual from wandering outside the home, which could be of some danger because they may get lost or not know where they are. Preventing falls, preventing themselves from being hurt in any other kind of way. Managing behavioral and emotional disturbances. So things like they're asking me the same question over and over. These are things that they're faced with. They're faced with irritability. They may argue with the individual. Verbal aggression, sadness or anxiousness, emotional kinds of disturbances. And I put a little asterisk next to this because historically what the literature shows is that these are the things that distress caregivers the most. These are the things that are unpredictable. They tell us they don't know what things are going to be like from day to day, if it's going to be a good day or a bad day. And I don't know if I'm going to be able to go do errands or other kinds of things because I don't know if they're going to need more attention or not. So that's very distressing for the caregiver. Other issues that caregivers face are arranging for medical care and in-home care, performing household chores, and managing the household finances and legal affairs as the individual that they're caring for becomes less and less capable of doing those kinds of tasks. So what are some of the consequences of caregiving? Well, there are physical consequences to caregiving. Caregivers are at a 35% increased risk for developing some form of cardiovascular disease over an 8-year period relative to similarly aged and health of people of similar age and health that are not providing care to somebody with Alzheimer's or a similar dementia. Among long-term caregivers, those that are caring for more than 2 years and do more than 14 hours of care per week, cardiovascular disease risk among caregivers is 95% higher than similar age and health non-caregivers. And we believe that this increased risk might be due to some physiologic changes that occur in the caregivers' bodies as a function of their being under a chronic strain. Two of the areas that we focused on in our research are biomarkers called D-dimer, which is a measure of blood coagulation. It's been found to predict pulmonary embolisms, deep vein thromboses, and coronary heart disease. And a second biomarker that we've focused on in our study has been interleukin-6. This is a measure of inflammation. It's activated as an immune response. It's been found to predict coronary heart disease. On that note, I'm going to present some research that confirms the risk that D-dimer and IL-6 present to individuals. This is not a study of caregivers. This is just a study of D-dimer and its correlation and relationship to future coronary heart disease. So what they did was they divided individuals in this study out into 3 tertiles. The people in the lowest 33% D-dimer in their bloodstreams are the reference group. And then if you move to the second 33rd percentile and the highest 33% of individuals, you can see that the risk grows, that if you have the highest levels of D-dimer in your bloodstream, you are at the highest risk, nearly 40 to 50% increased risk for coronary heart disease diagnosis in the future. So yes, D-dimer is of some relevance to determining health as a marker of health risk. What about interleukin-6? Same kind of thing, except they broke it out into into quintiles. And so each section here, 1, 2, 3, 4, and 5, represent a 20% increase, or you're in the next 20th percentile of IL-6 in your system. And again, you can see that as IL-6 rises in individuals' bloodstreams, they are, if they're in the highest levels of IL-6 in their bodies, they're at more than twice the risk of developing coronary heart disease long-term. So D-dimer and IL-6 are measures of health risk. What do they look like in caregivers and non-caregivers? What you can see here in this blue sort of purple and section of what are the levels of D-dimer in the bloodstream for caregivers. You can see that it's significantly higher at a single point in time than individuals who are not providing care to somebody with Alzheimer's or related dementia. This was part of our research, one of our research studies here at UC. And this is that was a snapshot at one point in time. This is longitudinal data. You can see that over time, the red line represents caregivers. The blue line represents non-caregivers. As caregivers age, their D-dimer levels increase at a faster rate than non-caregivers do. So the term we use to describe this effect is accelerated biological aging. People are potentially at higher risk over time than if they provide care to somebody with dementia or some kind of Alzheimer's or dementia relative to individuals who are not providing care. That's D-dimer. Similarly with IL-6, you can see here caregivers have at one point in time higher levels of IL-6 than non-caregivers. You can also see from a study that was done by Janice Keith-Colt-Blazer at Ohio State University that caregivers have accelerated biological aging in terms of their levels of IL-6. It's accumulation of IL-6 in the system, which then raises their risk for potentially having coronary heart disease or other cardiovascular kinds of illness. Excuse me. So we have data that shows that caregiving because of the stresses of caregiving, people may be at risk for developing physical health problems. But what about emotional strains of caregiving? This is a far more well-studied area. And just some highlights here. 61% of caregivers report that they are experiencing high or very high emotional strain as a function of providing care to their loved ones. In our study here at UC San Diego, we found that 5% of non-caregivers compared to 40% of caregivers reported clinically significant symptoms of depression. Clinically significant meaning that they may need some form of psychiatric or psychological care to manage those symptoms. And we also noticed that the increased emotional strain has been linked to increased risk for mortality. This is a study that was done in 1999. It was published in the Journal of the American Medical Association. Richard Schultz at the University of Pittsburgh conducted the study and found that 4.5-year mortality risk for caregivers was 63% higher than those who were not providing care to someone with dementia or Alzheimer's or some form of dementia. Caregivers with high emotional strain had an 8% increased risk, but caregivers without high emotional strain had an 8% risk of higher risk of mortality, but the caregivers with high emotional strain had a 63% increased risk of mortality. And what that data shows to me is it's not being a caregiver that puts you at increased risk for mortality. It's being a caregiver and having the strain and the emotional issues that go along with it, like the depression that we talked about previously. So if we can find ways to mitigate the emotional strain of caregiving, we might be able to lower the individual's risks for health consequences. So what would be a treatment target? Depression might be a treatment target to help individuals not only have higher quality of life, but also have improved physical health status. So increased risk of depression is associated with increased risk of emergency room hospitalization. That's been shown. Greater symptoms of depression have been shown to be at putting caregivers at greater risk for cardiovascular diseases. Greater symptoms of depression have been shown to have correlations with higher concentrations of D-dimer and IL-6. So what is the summary of what we see about the consequences of caregiving? There are both emotional and physical consequences. Those consequences are quite serious. The emotional and physical consequences appear to be linked to one another, and the emotional and physical consequences can result in extreme pressure on the healthcare system through increased costs because individuals become at greater risk for depression. They become which requires care. They become at greater risk for cardiovascular and other illnesses, which will require care. So now let's move on and focus on the Pleasant Events Program and what can we do to try and help individuals. So this was a study that was born out of exactly what I just talked about. There seem to be links between depression and emotional strain and health consequences. So the primary aim of our study was to determine if a brief behavioral activation-based intervention is more effective than a time-equivalent support and information condition for reducing depressive symptoms in caregivers. We also wanted to see if this same intervention could successfully modify physiologic cardiovascular risk indicators relative to the information and support condition. And we don't want to focus just on statistical results. We really want to focus on clinically meaningful information, stuff that you can say, oh my gosh, it's not just P is less than 0.05, and that's wonderful from a statistics perspective, but what is really happening in these individuals in terms of their reduction in depression and their reduction in these biomarkers. So let's talk a little bit about what is this PEP, Pleasant Events Program therapy. It's very brief, it's 6 sessions. It's focused on behavioral activation therapy. And it's been tailored for Alzheimer's caregivers. 4 of the sessions occurred face-to-face in the caregivers' homes. They lasted about an hour each. The final 2 sessions were phone calls, really focused on, are you using the things that we're teaching you on a weekly basis? There's 4 key components to this intervention. First is, caregivers are taught to monitor their use of their time. What are you doing each day to help self-care types of activities, particularly leisure and meaningful, rewarding kinds of activities? Then we help the caregiver identify candidate activities that they think they could be successful at engaging in. So what are the 4 key components of this intervention? Well, the first thing is that caregivers are really taught to monitor their use of time, especially the time that they're spending in meaningful, values-based activities, things that really matter to them. They could be leisure activities, they could be social activities, but they really are activities that they think matter to them. Then they're asked to identify some candidate activities that they would like to engage in and that they feel that they could be successful in doing it. It's really important to pick activities that they could be successful in doing. The third component is to develop what's called an activity hierarchy. And this relates to what I was just saying. It really helps them to prioritize activities that they can be successful in doing. And fourth, just schedule some time each week to engage in and set goals for activities that you will do. And also really just track their mood as they're engaging in these activities to help them with feedback to show that what they're doing is actually mattering in terms of how they're feeling emotionally and their well-being. So this is a worksheet that we have in our treatment manual where it's one of the categories of activities that a caregiver might like to try. It's the hobbies, arts, and crafts. And so you can see here that the individual might say, hey, I wouldn't mind trying to play a musical instrument this week. That's something I really enjoy. Just to help them sort of brainstorm activities that maybe they hadn't thought about or that they didn't think that they could do, but here's some things that you might like to try. Oh, maybe I'd like to try some kind of artwork or craft. And then what we do is after they get done, there's a number of activities. Some of these things may be social activities, some of might be the arts and crafts, some might be volunteerism or other kinds of things. But either way, they go through these long lists and they just check which things might be of interest to them. And then they're asked, pick 15 of these things or 10 of these things and rank them in terms of how easily you might be able to do them this week. So in this case, someone might say, well, I could certainly go out and get outdoors, take a walk. I might even be able to bring my loved one with me as I do it. But I think I could probably do a walk. That would be my number one sort of easiest activity to do. Play the piano. I could probably set aside some time this week to play the piano. And then you move down the list. I'm not sure. It's not clear to me. Maybe I could try and have dinner with a friend, but it might be more challenging. So I'd rank that as 6 on my list. And then, of course, the least likely thing that I could do is take a vacation. So that would be sort of a future goal of mine. But really what we're trying to do is help them to sort of prioritize achievable things for this week that they would get some value out of doing. And then we have them track, did you do these things each day? So you can see, yes, the person did the walk on Monday. Yes, they did the walk on Tuesday. Didn't walk on Wednesday, didn't walk on Thursday. It's so forth and so forth. So if this person set a goal for the number of times they'd like to get out and take a walk, and they meet that goal, as you can see at the end, they circled the G, I've met my goal. So even if I didn't do it on Sunday, but I know I met my goal, I don't have to feel so bad that I didn't get out and walk that day. It's sort of just to help you realize, hey, it's nice to know I met my goal, and that's the important thing. I feel like I got a sense of achievement from doing this. And they can do that with all the activities that they set themselves up for. But really, it's just helping people track and self-monitor their successes and what they're actually doing with their time. As you go through this study, you can see, in this case, the person started with only doing 1 to 2 activities in the first week. They started to increase the number of activities that they engaged in. over time. And you can see that this person was able to move up in their engagement and getting something out of the activities that they're choosing to do, self-care types of things. And as they were monitoring their depression, this is an example, this is not a specific person's data, but then they can also see, gee, the more I'm doing for myself, the more that I'm engaging, the more that I'm setting goals and achieving them, the better it makes me feel. I'm reporting less and less depression. So that's the goal of this therapy. What about the support and information condition? This was also 6 sessions. It was equivalent in time, 60 minutes, 4 sessions in the caregiver's home, 2 sessions by phone. The key components of this intervention, it's not really a control intervention. It's not a nothing intervention. It does offer supportive therapy, but it also has an information book that talks about local resources. And it also has sections on skills. How do you manage somebody when they're having problem behaviors, distressing things? How do you problem solve? What are the steps to setting problem solving goals? Learning how to reframe your thoughts so that you can feel a little bit better. Communication skills, financial and legal issues, placement issues, nursing homes, kinds of things like that. So it wasn't just, it was an information guidebook that did teach some specific skills. And over those 6 weeks, the caregivers would select the issues that they would like to work on, and they would work with the therapist on learning the skills and practicing them between meetings. Okay, so let's talk a little bit about the results. The first slide that I have here is the statistical results. As you can see here, the red line is our active sort of pleasant events, activity-based intervention. You can see that it was significantly better from baseline from pre-treatment to post-treatment. It did lose some of its effect across a 1-year follow-up period, but it did show some immediate, yes, individuals who were in that treatment showed a significantly greater decrease in depressive symptoms than the people that were in the information and support condition. But let's talk about the clinical meaning of some of this. This is a little bit, I hope that people will understand this, but really what I want people to focus on, and if I can just pull up my laser here. Nope, that's not it. Might have to go back on that one. Can we push pause and go back? I have to find this slide. So now let's focus a little bit about the clinical reduction in depressive symptoms, the meaning of all of this, not just a statistical approach. So what I want to do here is I really want to focus on this section right here. So we had 50 people in each treatment condition. And when we start with, from where each individual started, what now percentage of these individuals showed at least a 10% reduction in their depressive symptoms from when they started the therapy? What percentage of the participants showed at least a 20% drop in their depressive symptoms? So what you can see over here is that in both conditions, quite a few individuals in each of these conditions showed at least a 20% reduction in their depressive symptoms. And that's what we hope for in any kind of therapy. But when you start getting down into 50% reduction in their depression, which is really quite meaningful for people to see a 50% reduction in their depression, you can see that 1/3 of the individuals in the pleasant events activity-based intervention showed at least a 50% reduction in their depressive symptoms, but only 12% of people in the information, support, and skills-based intervention showed the 50% reduction in depression. And that is quite meaningful. And then we go on further to at least 60s and 70% reduction in depressive symptoms. But what exactly is a 50% reduction? What is that? So now we're looking at a depression scale called the CESD, the Center for Epidemiologic Studies Depression Scale. Many people might be familiar with this scale. It's a very well-validated depression scale. It's used quite a bit in caregiver research. Let's focus down here. How many people in each of these conditions saw their CESD depression scale score go down at least 8 points? 1/4 of the individuals in the Pleasant Events program saw an 8-point or more drop in their depression. only 8% of individuals in the control information support condition. That's where I really think the clinically meaningful change in depression can be highlighted. So let's talk a little bit about response in interleukin-6, one of our biomarkers. What you can see here is that individuals in the support condition actually saw an increase from pre to post treatment in their interleukin-6 levels, whereas people in the pleasant events program saw a reduction. And this is statistically significant, quite heavily so. But then there was a normalization here among this group so that by the end of a year, there was no difference. But here during the active treatment phase, quite a bit of difference. What about the clinical meaningful things? Let's go back to focusing on the 50% reduction in interleukin-6 again. What does that look like? 18% of people in the PEP intervention saw a 50% reduction in their interleukin-6 levels. Only 6% of people in the control condition saw that level of response. So yes, this is some meaningful reduction in interleukin-6 with implications for health outcomes downstream. Finally, the other biomarker that we studied was D-dimer. What you can see here is that both groups saw some reduction in D-dimer from pre to post treatment. The individuals in the pleasant events program maintained a lot of their reductions so that they were on average lower than when they started. Individuals in the support condition, once their intervention was over, they saw their D-dimer levels rise to higher than their baseline levels. Don't have the clinical data on that, but let's talk about what are some of the really important points to take home from this presentation. First, I want to highlight this pleasant events program is a very brief 6 sessions targeted behavioral intervention that's aiming at increasing engagement in enjoyable and meaningful activities in a person's life. Overall, the pleasant events intervention was more effective than the support condition for reducing depression. There also seems to be evidence showing that pleasant events participants had lower information levels at post-treatment compared to the support condition. Coagulation seemed to be higher in the information condition at 1-year follow-up. What are some of the strengths of this intervention? Well, it's one of the first interventions to measure health outcomes related to cardiovascular disease risk, in addition to measuring changes in depressive symptoms. This is also a strength, is that the support condition was not really just a support, active listening kind of intervention, but they were actually taught skills to help them manage some of the stresses if they wanted it. So it wasn't a true control condition, it was an intervention comparison. Our results appear to be favorable compared to other interventions, and that's because statistical studies aggregated, if you look at all the studies that have looked at the effectiveness of interventions for caregivers, most studies will have what we call effect sizes, how strong was the impact of the intervention on the outcome, that were pretty small in magnitude. Our intervention seems to have stronger magnitude of impact on depressive symptoms and seem to have meaningful impact, moderate levels of impact on both physiologic outcomes that we measured. So that's compared to other caregiver interventions. This one seemed to have some pretty strong, relatively stronger impacts on the outcomes that we measured. Another advantage of this study was that our intervention is brief. Many other studies that have been out there for caregivers are as many as 10 to 12 sessions, sometimes taking as long as 2 hours if they're psychoeducational interventions. Ours was a 1-hour intervention, and it was 6 meetings with the person. And the other advantage, I think, of this intervention is that it's going to be relatively easier to implement and get out there in practice. It's an intervention that's not complicated. You can easily train therapists at all levels to deliver the interventions. Even bachelor's level individuals can deliver this intervention if well trained. It's also brief, that it could be accepted more by providers because they don't have to invest as much time to deliver the intervention, and it could be delivered in a variety of settings. Now, I want to talk about, we previously talked about the REACH study, the national study that was done across 6 cities and over 1,000 caregivers. That study, the outcomes of that study are still, this was 20 years ago, but it's still considered the gold standard intervention for caregivers. This was the conclusion that was made in the paper. Quote, if this intervention was a drug, it's hard to believe that it would not be on the fast track for approval. The magnitude of benefit and the quality of evidence supporting this intervention considerably exceeds those of currently approved pharmacologic therapies for dementia. So they're highlighting that that intervention was highly effective. And it would, if you saw this as a drug, it would just get fast-tracked to getting available to everybody that they possibly could. Now for the but part. It offered a level of caregiver support that few clinicians will be equipped to offer to their patients because it's too complicated to implement. That's why I highlight the advantage of this particular study, because it's so simple and it's easy to learn, and caregivers will understand the details. They don't have to spend so much time really parsing out, how do I implement this into my day-to-day life? So even the study investigators who published their results in a high impact medical journal were had to acknowledge few people are ever really going to actually be able to use this intervention in a clinical basis. So what were some of the limitations? The sample size was relatively small. We only had 100 individuals who participated in this project, and that made it a little bit difficult to detect the effects that we wanted to find. We didn't have the ability to detect if this treatment worked for people across race and ethnic lines. So we had a relatively small number of individuals of a diverse ethnic and racial backgrounds. So we don't know how this intervention will work in other populations of interest. And finally, we don't know how well these results, seems that there were some outcomes that didn't persist across 1 year. So we need to find ways to sort of bolster the effects of this intervention over the long term, help people to use the skills that they're learning and apply them consistently across time. Thank you very much. I appreciate the willingness to be part of this presentation.